Hey everybody, welcome back to the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Over there on my left, that's Caleb Ferroni. Way over there to the right, Dr. John Hill. And AJ is returning, and welcome aboard. We are sad to kind of announce that you'll be taking the place of our regular host, or one of our co-founding members, Ray Pace, who is still amongst us, and he's promised to pop in and join us a couple of times a year, but sadly he's focusing on his chief duties as he should, and his education duties. So AJ, welcome back, and welcome as a kind of a regular part of the team.
Yeah, appreciate it.
We're going to be not only announcing AJ, but a few other names that we're gonna sprinkle in here and kind of mix this up a little bit, because I'm sure you're tired of hearing me talk after what we're in 3 years yet.
This is
starting year number 3. I can't believe it's been that long of a journey already.
So, I mean, I think it'll be a good change. We've tried from the beginning to have a rotating course of physicians on here from different viewpoints, and now increasing. AJ's got a different viewpoint than the other people coming in, and what they work and the type of environments that they work in. So I think it'll be good for us.
Yeah, for sure.
Yeah. And like I said, we got 2 more we intend to introduce into the rotation here, and then hopefully that'll even. We've had some ideas to do some other expanded products as kind of offshoots of this podcast series, and hopefully we can start capitalizing on the additional the additional kind of workforce here, and work on a few of these things. So I'm really interested to see what 26 brings us. But we're talking about 2026. Guys, just 2 days ago, we're kind of zooming ahead here. Just 2 days ago, there was a release to the Ohio Scope of Practice, and this is really going to kind of be a Ohio-centric kind of talk here, and really pointed at what we're doing in state. And I guess let me kind of preface some of these changes we're going to talk about. Over the last year, all of this has kind of evolved. And in some regards, we're kind of catching up with some stuff that has been done elsewhere in the States, and we'll talk a little bit about why all of a sudden we're making this big pendulum swing to. Not that we weren't bad. It was never really all that bad. It's not like we were Mother May I on a bunch of stuff, but there were certainly some gaps, and we're seeing that pendulum swing and things open up, and there's reasons for that. We'll talk about that in just a minute. But we want to talk about the changes. And if you're in the UH sphere, you've heard a little bit, and you've seen in protocol changes over the last year some of these things implemented already, but.
Also, to add to that, most of us have not seen these changes yet.
Yeah, and then
so it's going to be live with you.
Yeah. So we just got the email notification before we started recording.
Yeah. I mean, 30 minutes ago, the email notification came out. I saw these on the website, and we elected to do this. So a couple of these changes are literally going to be new to the 3 of you. So I want to hear your raw reaction on them, which will be kind of something a little different for the way we've done things historically, but. Let's kind of talk about how we got here with the changes that have happened over the last year. So in Ohio, there used to be this kind of coupling law that put the scope of practice in line with our educational standards. So if you basically...
Which honestly made a lot of sense, right?
Entire sense, right. Yeah, you can't even be mad that it is. However, if it wasn't taught in primary education, if it wasn't part of your initial offering... we didn't go beyond that. We didn't. Let me say it this way. It was my observation that we didn't stray far from that. There were some things that I think, born out of necessity, have been allowed over the years.
Which 12 leads diagnostic EKG was part of that, right? Probably not part of your initial education.
Oh, it absolutely wasn't. Right. That was added on in subsequent years, right? And that's what they said. Okay, well, it is being taught. Yep. Now, there was no retroactive, we were kind of grandfathered in. It's not like that scope was so intimately tied with everybody's certification in the state that they made us all go back and relearn that. But yeah, I think we absolutely talked about that before, where things that just absolutely weren't taught, and it was still explicit domain of the physician when I went to paramedic school.
Sure.
Like, you step out of the room, you're too dumb to even understand what these squiggly lines mean, right?
Yeah, we weren't taught that 22 years ago.
Right. Yeah. So so that decoupling law opened the door for other things to be added that subsequently, nobody was trained in primary education, because if you really wanted to open up the things that could be done with the paramedic level specifically, we may as well go to medical school and be a doctor, right? Because it would just continually, expand. So they decoupled that from a lawmaking perspective, which allowed for the EMS board to hang that responsibility for other acceptable, within the EMS space, other acceptable interventions and other acceptable treatments, hang that responsibility on the medical director, at the local level, right? So,
which I think brings up the point to talk about Ohio being a home rule state, and that if you are outside of Ohio watching this or listening to this, protocols dictated by the local medical director. We have a lot of leeway in things that we can allow you guys to do. We're not beholden to what the state says you can do from a protocol standpoint.
Yep.
You're beholden by what you can do from procedure level and by what you can teach.
Scope,
I can't authorize you guys to go out there and do appendectomies out in the field, right? Yeah. That's not within your scope of practice, but I can authorize you guys to do cricothyrotomies. You can do invasive procedures, which I'm sure we're going to talk about some of the newer invasive procedures that are going to be coming to the state of Ohio, but that's different from, say, Pennsylvania, being that the state sets what protocol is.
Right. The you use the appendectomy kind of tongue-in-cheek. I think the one that probably resonates a little bit more with the EMS community is C-sections, right?
Yeah.
You can't. It is expressly prohibited in scope of practice. You are not then permitted as a medical director within the state to exceed those boundaries, right? So you can write your protocol or authorize your provider to practice up to the scope of practice, but you cannot exceed it, right? And that's how we.
Well, and I think we draw that line there because the resuscitative C-section is within my scope of practice to do in the emergency department. And even outlined in the AHA update in 2025 saying that setting those time limits of what it should be, and they say less than 5 minutes from arrival to the emergency department. And honestly, our goal is 60 seconds from arrival to getting that baby out.
Yeah.
So if as soon as I start essentially dumping iodine, cutting, and trying to get baby out, it's the one there's two procedures I have not done that are in my scope. That is one of them, and that's the one I absolutely never want to do.
Yeah. Don't want to have to.
No.
Yep. Do it long enough. It's
correct.
One of those things.
I hope not.
So.
But to your point, I get what you're saying. Like, you can't have a physician say, "Hey, I'm going to take over you as medical direction, and I'm going to allow you to do field amputations whenever you want because I want you to." Well, if the state says you can't supersede it. So
I don't want you drilling burr holes in people at the side of the road.
Yeah.
Yeah, I mean, because that would be the next thing, right?
It is.
With your easy IO and a.
I was just going to say that there is published literature on
there
using IO to decompress a brain. So.
Yep. So the way the state of Ohio, and this is funny, this comes up again because it was it last week or 2 weeks ago that I was encouraging, we kind of identified a gap in our education at our paramedic program. And, my homework assignment for the class was, hey, you guys need to go back and look at the scope of practice. Because even though we're teaching to it and we're teaching protocols within it, we really had never said, hey, take a step back and let's look broadly at the umbrella in the state of Ohio. Because some questions came up specific to that. And they're like, well, can we do this? Can we do that? Can we do this? And I'm like, well, why are you kind of asking me this? It's already defined.
Well, I just got that question from my nurses, like, can they access ports in patients? I'm like, well, let's go to let's look it up.
There is a place to see this.
Yes, you can absolutely.
And
really, the more question was not that most EMS providers are not going to be accessing those ports directly because most likely you don't have the equipment on the ambulance. However, oftentimes if you're doing interfacilities,
they may have
it
that
might already
equipment.
be there. And then the question being is, like, can EMS they're not putting the needle in, but they're accessing the line. Absolutely, they can use that line
100%.
to give medications.
So the way that this drafts out, if nobody's ever looked at it, is and the state does this. I think the way they do this is actually kind of nice.
It is. It is.
Is they put it in this matrix form.
And for as long as I can remember, maybe you guys can say different. It's been that way.
Yeah, it's been this way since I've been paying attention to it, and that's been, 25 years, right? But that I've been paying attention to it. Admittedly, in the first 5 years of my
you knew it all. You were out of school.
Exactly. Yeah, right. I was really high on that Dunning-Kruger effect. So yeah, didn't need to read.
Not knowing anything, but think you do.
But think
Correct.
you do. Yeah, right. I was up here. Right. I think we all are. Might still be stuck there.
Some of us.
But they break this down into just a matrix, a grid, with the columns representing the different levels of certification in the state of Ohio, from the EMR, the EMT, the advanced EMT, and the paramedic. And then listed out are all the appropriate procedures for each on the far left column. And then there's X's in where it is permitted. So it's actually a fairly easy read. You tell somebody to go look at scope of practice, and they immediately, I don't want to go there.
No, it's not bad.
It's really not that bad. I saw some eye rolls when I asked the class to do that, and then when I debriefed them on the following day that I was teaching, they're like, that gave us some optics on where
it's probably good that you should
where the boundaries.
Know, A, you should know where to find your scope of practice.
100%.
B, you should know what your scope of practice is.
Yeah.
So C, when you're on the phone with online med control, especially if you're in paramedic class and you're operating as a paramedic student, then yes, you can do those paramedic procedures. But if, let's say, you're an EMT basic and you're working in your home facility, you need to know what you can and can't do from that. Because you have not passed and you're not a certified paramedic yet.
Yeah,
that's a good point.
You're literally practicing up to that, but you haven't taken that step quite yet. So along with this matrix, the other kind of structural change they did for 2025 is we broke this down into core competencies, and then we had these added competencies. And these added competencies are kind of what we're speaking to here. Is
that's kind of cool.
The things that we're adding, and essentially making it incumbent upon the medical director to approve, train, and subsequently allow, right?
I guess that's a really good point to stretch there for a second. Just because it's in your Ohio scope of practice, and I know we've said this already in a way, doesn't give you the rights to just go do it under your protocol.
Yep. I guess we can hammer down on that a couple of different ways here, but it's an added competency, but it requires specific training.
Well, I'm saying even outside of the added competencies, that even with our own protocol, there are certain things that you're allowed to do under scope of practice as a paramedic, but need local med control authorization to do.
Correct.
Cricothyrotomy is the one thing that comes to mind.
That goes back to your authorization. You can't exceed that, and especially the way we handle it in kind of the Northeast Ohio regional perspective is all of the things are written into the protocol, but then they're individually flagged out as, hey, your medical director has to authorize this. Surgical cricothyrotomy, so that can versus a cricothyrotomy kit, needle cric, I think, is authorized for everybody. But the point, your point is well taken, is you, John Hill, can say, hey, I want this department. I'll allow this department to do surgical and needle and cricothyrotomy kits, but due to reasons, maybe that's call volume, maybe that's provider experience,
also,
right?
RSI's in that category too.
RSI is another great example. High dose tranquilization ketamine for the advanced EMT, right? The way it's written in our protocol, allowed by scope of practice, but the way it's written in protocol is it gives the physician the ability to determine if that is appropriate for their department. So again, if you have a department that has only a few members and they don't go on all that many calls, it's probably not wise to allow them to tranquilize people, right? This is stuff you have to be intimately familiar with and do and be prepared for.
Especially when it comes to high dose ketamine, there are lots of examples we all know about, news stories, and there's bad outcomes, and we don't want bad outcomes. We want high quality care. And if, as a medical director, I don't think that you guys can provide that high level of care, I'm not going to authorize you to do the more riskier things.
Yeah.
And we've had that conversation about what drugs are in the drug box and what are the more dangerous drugs. Obviously, paralytics, ketamine is going to be in that list. But honestly, for me, and why it's red boxed in our protocol is the beta blockers.
Yeah.
Those are very dangerous drugs.
That's a great, I mean, I've said it before on this, and I say it to my class. I know physicians that mix up the beta blockers and have chosen the wrong one for the wrong case, and cause
Tocopherol versus labetalol in this case.
Absolutely right. And we have both of those beta blockers
for two different things.
For two very different things, and they have two very different pharmacokinetics and pharmacodynamics, even though they're in the same drug class, and that's why we...
Even going beyond that, there's different pricing for them, and honestly, some of the metoprolol is a medication that's a lot more available than labetalol is, and labetalol will often go on shortage.
Oh, fair.
So we don't want to burn, if we don't want to and we've had that conversation before when we talk about drugs, is that we want to standardize drugs, we want to minimize the number of drugs in the drug box, and we do that for a number of reasons, and a lot's for safety.
Yep.
We would love to standardize on one beta blocker to rule them all, but those drugs do different things at different times for different people, and it costs different money, and availability is very different.
Yeah.
I think also, too, to the speaking point, not everybody needs RSI. Not everybody needs to do surgical crikes, so you have to, as a medical director, understand that there is either a need or a potential need for those advanced skills, because if you're not going to be using those skills, what's the point in training on them? RSI still, per the state, we have to do quarterly refresher courses and initial courses, and it's a lot of upkeep for something that you may not need.
I think some of those... I put a few of those points out there to basically kind of lead up to this. Is there's a lot of hurt feelings when you say, I trust XYZ department but not this, and people have to
take it personal.
They absolutely do, right? It's like, well, they can do it, why can't I do it? And you have to zoom out and look at your, and look at all of the factors here, right? Is it safe for the patient? Well, if you're at a department that, and you're on a department that's very busy and you can keep your skills up, but you're also, volunteer part-time or something. I'm not picking on them. I came from such a place.
I did too.
I came from such a place. Yeah, right. I came from such a place.
Yeah.
I remember wanting to do more and do more and do more, but I was on a department that ran 190 calls a year. Is it safe?
Yeah.
And those things have to be digested by your medical director or their team, and looked at comprehensively rather than just as a
So from a medical director standpoint, I've got a few agencies. None of my agencies right now do RSI. I've had a few agencies approach me about wanting to do it, and then I lay out what my criteria are for it. Then they go look back and they realize that from a agency standpoint, they're not meeting that criteria. So we have that conversation. They understand what my reasons are and why I want to do it. Oh, we're not meeting this for first pass rate, for IV access, for all these things. I need to be really good at the basics of paramedicine before I do the advanced things like RSI.
Yeah, prove this to me. I'll consider the next thing.
Absolutely.
But I think that's a perfect segue into the fact that the medical director is very involved in these specialty things that you may not get it, or you may, and that's where you have to have a very good relationship with your protocol departments. And I know that our med director does for my firehouse, and he's constantly there teaching and being a part of it. And I think that speaks volumes to what you have to do too to make sure that, hey, I'm not just going to bless you because I want to bless you and make people happy. Be part of it. Yeah.
Because it essentially falls back on you.
It does, yeah. Ultimately, it does, yeah. Especially when we're talking about the high risk stuff and obviously the additional stuff, and in protocol that we have the benefit from the regional aspect, that a regional physicians amongst different even different hospital systems, right? So we have 3 hospital systems that multiple doctors that all agree on this protocol, And then even within UH, we then agreed on what our protocol says. And each hospital system has their own little caveats and deviations from what regional protocol is. Not enough to even write home about, to be honest with you, or even discuss. There's just little asterisks to know those specialties. But ultimately, it's my responsibility that if one of my agencies messes up or doesn't do it, it's going to fall back on me.
Yeah, and the provider too. I mean, but ultimately you. But I mean, we just had a conversation the other day that somebody did something within their scope of practice correctly, and then the receiving hospital, who our med director doesn't work at per se, he's with the system, but he's not usually there. The receiving physician didn't understand that was part of our protocol, and there became a big verbal conversation there about, did you do this, and why would you do this, and are you allowed to do this?
Connect the docs.
Yeah,
that's right.
Yeah, so that's exactly what happened. But it's like, as long as, I mean, it could come back on us also. You have to understand that the physicians we're transporting to aren't the same every time.
Well, and I tell my crews that, like, when you're calling for online med control, you may not be getting an EMS physician.
Yes.
Now, at my shop, and this literally just came up this last week, I said, so we typically have 2 docs working on during day shifts. The docs want to spread out the EMS calls. That's a reasonable thing to do, so you're not inundating one doc. However, I've got 2 EMS medical directors, so if the EMS medical director is doing it and an EMS call comes in, just give it to the EMS doc. Like, we want to take those calls because we know protocol. We know the differences between basics, advanced, and paramedics. Yep. We know protocol. We know what we've authorized to do and not do. I'm the best person to take that call. But in that case, and you said, connect the docs. All of my providers know where to find my cell phone number.
Right.
And if they want to, hey, I'm going to call my medical director, get him on the phone, I'll answer that phone call. I'll explain why.
Work through it,
And having a doc-to-doc conversation, and we've said this in the past, like, we can have a quick 15, 30-second conversation and it's all smooth over and done with. It's not a long call. It's not a long call. It's not a long conversation.
The other, I want to make sure that there's one very, very special word put in there with the relationship between the provider and the medical director is, we are given the privilege to work under your license or a physician's license. Yeah. And I think that often gets taken for granted, right? Every medical director becomes a medical director because they want to, by extension, take care of patients and help patients, right?
Yeah.
But you don't have to, right?
I don't.
And you wholly own your license. It is not something that you have to allow anybody to operate under. And it's come up in a few... through several vectors over the years, right? But nevertheless, I think that needs to be comprehended by everybody, right? It's he or she is extending that courtesy to
and
you.
Can easily withdraw
and can withdraw as fast as.
And we have withdrawn.
And we absolutely.
In appropriate extreme circumstances where there has been a huge violation of trust. Not even protocol.
It doesn't
trust.
have to, and that's and that goes back to that. It's a privilege to do it.
Yes.
It's not something that.
And flip that around when you're thinking about it in your mind. Imagine if the roles were reversed. Imagine you're the medical director. Or a better thing would be you're supervising a student, right? They're operating under your certificate as a paramedic, and then that in turn you're operating under whoever your medical director's medical license to practice. You guys in the state of Ohio are not licensed individual practitioners. You hold a certificate in the state of Ohio extending underneath whoever's medical director it is. Yeah. If your student messes up, that's on you.
Correct.
Yeah. Same thing here. I have then to explain why such and such happened if it was obviously flagrant, right?
Yeah. But I think we've talked to this before. I mean, what's the first thing you should ask that provider if something messed up? Like, when did you catch it and when did you report it? And if it's, if I try to hide it, that's when things go south. It's usually, hey, I messed up and I want you to know that I messed up. You're probably going to get a talking to and maybe a little bit of training, but people make mistakes. We're humans.
It's also very different if I were to immediately call my medical director and said, hey, I messed up and I know why I messed up. Right?
Yes.
And then I lay... All right, here's what I did, here's why I did it, and here's what I'm going to do moving forward. That's a very different adult conversation rather than, I messed up and I'm ready to take a tongue lashing, which is a very different conversation than medical director found out about it 3 months after the fact in a chart review.
And that's what I'm getting
Yeah,
at.
exactly,
Yeah.
right? Those are very, very different things, and that's it.
They are, and I had a very similar situation where someone gave the wrong medication. Person A did it, hit it. I didn't find out about it. Person B did it, actually works for UH, called me immediately afterward and said, hey, I messed up. Person A, who didn't tell me, got lashed at, got a tongue lashing, had to do re-education, and then their agency demoted them.
Yeah.
Person B, who called me, said, and they knew what they did, they know why they did it. It was at 3 o'clock in the morning, they made a mistake, they grabbed the wrong drug. Accidents happen. I trust them because they called me right away.
Right.
Hey, I messed up. This is what happened. And then I got a call from the receiving hospital. Hey, this happened. Yeah, I already know. The provider called me. We already fixed it. Okay, great. That's it, as long as it took.
That gets
I know.
Turns out doctors can make mistakes too. And I mean, you're
On a
human.
daily basis,
We're human. Yeah.
Yeah, and that gets documented, and we're everybody's looking for a pattern, or if there's a reoccurrence of a similar or the same thing, and maybe that we have to go back from a systems standpoint and look at how we're conveying or presenting information.
The one thing I will say is
people.
I have never had an issue. I mean, if you're in clinic, you're in clinic. You'll get back to me, but I have never had an issue getting hold of my med director if I needed to. There's always 10, 15 minutes later, if they're in clinic, like I said, you'll get a phone call back. And I think that's one thing that's really good about our med directors, and I hope that it's statewide, that you can get a hold of them.
Yeah. I also think that trust thing goes both ways. You know what I mean? So they got your trust.
Welcome aboard.
So, like, if you look at the example, like you go to that facility and there's a question about it, as long as you did that right, that medical director's going to back you up, and you can trust that they have your back as long as you followed everything appropriately. So
I don't know any med directors out there looking to throw anybody under the bus.
Yeah.
Like you said earlier, it's a kind of a privilege that we have it, but it's also a privilege that you have us, because we're making your life easier in the ER if we're doing our jobs right.
Absolutely. And most of the time, if you make a mistake, I want to know about it as an education point, right?
Correct.
Yeah.
And when I notice that there are mistakes made, I actually like to do it with the whole agency, unless it needs to be private. But oftentimes during run review, hey, everyone, we made this mistake, and I'm including myself in that, right? We all made this mistake. Let's learn from it and not do it again.